exam one. I know that last time I used my iPad and you guys mentioned that it was really helpful. I left my iPad in my car, which is at the mechanic, and they don't open until 9. So I was trying to figure out another way that I could still like show you stuff on the screen, help in a helpful way. So I have it open in PowerPoint, and then from here I can like highlight things and use my like use an arrow. So we will troubleshoot this and hopefully it's still more helpful than just like looking at the slides with me. So anemia part two is your normocytic anemias, your macrocytic anemia, some into hemolysis as well. I went back through the slides, these slides, and I trimmed it down a little bit. I think last time we ended up like a little bit like longer than I had expected for the lecture, which I don't mind, but I know you guys often have like classes backing right up to it. So I like to give you like 10 minutes at the end of lecture, at least between classes if I can. So I trimmed some of this down because some of them were just like kind of easy recall multiple choice questions. And I tried to make it some more cases. So a little bit less slides today, but hopefully still a good amount of substance. I also went through the PowerPoint and then anemia one and two, and was just counting like how many CBCs you would have gone over before exam one. And it looks like we will have looked at like 75 CBCs before exam one, like lab value tables. I tried to put a lot of lab value tables in this one too, so you kind of get used to that because it's the first exam you really have labs and then you have to interpret them. But it's never enough. Like just like watching me go through them and talking through them with me, you should also try to practice them on your own. I put some notes in there on our Canvas page. I think it's in like the, I don't know, the Heme helpful websites and study guide tips or something on the Canvas page. And I put like chat GPT prompts for making your own CBCs, which is helpful, or having it make you CBCs, but making your own is helpful too. And last cohort or last class, there was someone in the class who just like really liked, making test questions, which is a really good way to study. And they would always send them to me like after lecture or just like kind of whenever it worked out for their exams, and just have me like look over them and make sure their key was correct. And I'm happy to do that for you guys too. So if that comes up, feel free to reach out. So let's go ahead and get started with anemia part two. The first one is this old CBC here. I just wanted to show you that here the MCV says 98.7, and that's listed as high. But and this is not a number you have to memorize, we talked about MCV normocytosis being 80 to 100. So here, this is below 100, but it's still marking it as high. And that's because every machine has different levels of sensitivity and different, like, I mean, they have similar ways of interpretation, but you might see those ranges change when you're looking at different labs. So the case about this story is I had this patient who she would always have a macrocytosis every single time we did her CBC over years. And when I say had a macrocytosis, it was 98, 99. It was never over 100, but the machine said, hey, this is high. So I ran B12, folate, like the typical things that cause macrocytosis. We even did a peripheral smear for her, and everything was normal. There was no evidence of any issues. The other cell lines, white blood cells, platelets, totally fine. But she was really worried about these larger red blood cells, that the machine said it was larger. And she just really wasn't hearing that, like, it's not significant in isolation. And we checked the things that can contribute to it and so on. So she went to a hematologist, and they basically said the same thing. I remember when they sent the consult note back to me and they were like, this is not macrocytosis. It doesn't count unless it's under 100 or over 100. And I don't care what the lab ranges say anywhere else. I thought that was just interesting the way he wrote it. I imagine him just like really sarcastically typing it, but she insisted. And you will have those cases where it's like, I really don't think anything's going on. And the patients demand to see hematology for a smear, which is typically like the point. Sometimes, depending on where you work, the local labs will perform peripheral smears, but not all of them do. Some of them will do like kind of like an automated smear in a way. Like it'll tell you the abnormal cells, but they didn't do a manual review. So that's just something to keep in mind depending on where you work. So let's actually get into our macrocytic anemias. Which of the white blood cells are affected in megaloblastic anemia? So megaloblastic is a subtype of macrocytic anemias. And in that subtype of megaloblastic, we have one of the white blood cells that's also affected. Good. So answer here is neutrophils. And what happened? Those neutrophils. Let's actually table that. I tried to like slim this down, so I was like hitting on one topic each slide. So we have macrocytosis, and as I mentioned, there's megaloblastic, one category, and then there's everything else. So there's only two causes of megaloblastic anemia. They're nutritional deficiencies. We already talked about iron last class. What are the two other big nutritional deficiencies that cause large red blood cells here? Good. Yeah. Folate deficiency, B12 deficiency. Those are the only two causes of megaloblastic anemia. Here's our little lost B12. And here's a case that kind of goes along with it. We have a 23-year-old who presents with fatigue. Really generic complaint. And that's a lot of your cases for hematology will be they have fatigue, they have pallor, they are dizzy when they stand up. Well, that's any anemia. That doesn't help me, right? What helps me is like, oh, do they have a sign and symptom that's specific for this category of anemia? Like we did iron deficiency. All right, they're tired. They're pale. They're whatever it is that's generic, but they also have pica, right? Then that's iron deficiency. So here we don't have anything like that. We just have fatigue. So now I have to look at the labs to help me. I have homocysteine being increased, methylmalonic acid being increased, and smear shows hypersegmented neutrophils. So that's the change with the white blood cells. We have increased segmentations, hypersegmented. So right there, that tells me it's a B12 or folate because only the megaloblastic anemia does this. So now I have to decide between those two. Exams love to pin B12 and folate against each other. And this is our big differentiating factor. Homocysteine and MMA are both increased. So which one causes both of them to go up? A couple people, Eileen, Chris, you guys already got it. Yeah, B for both there. So here's seeing that. That case with B12 deficiency, and we can see that here, B12 is in the middle. I forgot my little arrow. It's kind of enormous. Okay, here's B12. So in order to make mature red blood cells, we need B12 for both of these processes here. So if I don't have B12, what backs up is, the products that were right before it, methylmalonic acid, homocysteine. So in B12, both of those go up, and folate deficiency, only homocysteine goes up. This table here, I tried to go through the exam and take some of the tables and then just like adjust the numbers and adjust like what was positive, what was negative. So this is a good example of like information you could get, and then you'd have to say, that's definitely B12, that's definitely folate. And you should be able to do that with the homocysteine methylmalonic acid. All right, so now looking at symptoms, we can look at MMA, homocysteine, that can help us. But what's something that they often put in the case that says that's B12 right there? Yeah, the neurologic side effects. Fatigue could be anything. Pallor could be anything, right? It could be any type of anemia. Paresthesia, that is very specific for B12 deficiency. And it's also what makes us kind of like feel a sense of urgency regarding treating the B12 deficiency because the neurologic symptoms can be permanent. So answer here is C. And then looking at this picture, I know GI is this semester for you. So you'll cover this in your GI course in ClinMed for that. But you also, I mean, we talk about it here and then maybe from physio. So this is the terminal ileum. How could disease here cause anemia? Say I had inflammatory bowel disease like Crohn's, not typically ulcerative colitis, and I had terminal ileitis, and the function of the terminal ileum was impaired. Yeah, it's all about absorption. And exactly, you guys are all on the right track. That's where the intrinsic factor B12 complex, that's where it's absorbed. So if I have Crohn's disease, which causes a terminal ileitis, or another issue with that area, or just colitis in general, it can cause an anemia from that. So next we have a 62-year-old woman comes in with fatigue, numbness, tingling in her feet. Neurologic exam shows decreased vibratory sense. She has no history of GI surgery. She is not on a vegan diet. So we look over here at her labs, and I have the ranges listed here, but hemoglobin is low, so she's anemic. MCV, let me get my little arrow out. MCV is high, so it's a macrocytic anemia. Red blood cells are low. Reticulocytes, nothing, that's not really helpful. Methylmalonic acid increased, homocysteine increased, right? So, right there, what do we have? If we don't even look at the last two, we've got the paresthesia, so we're already thinking about, right, B12. But then what drives it home is methylmalonic acid, homocysteine. So, we've got a B12, but what I want you to answer here is these last two, the antibodies, that points to the source of the B12 deficiency. So if I have autoantibodies against my intrinsic factor and parietal cell, what is that type of anemia called? It's still a B12 deficiency, but what's the condition called? Yeah, it's a pernicious anemia, which is kind of a, I think that's just a funny word. But yes, pernicious anemia. So you got, well, no, you're in Clin Med is next semester for you. When I was on the ground at Toro in Clin Med, they always had these worksheets that we did during it, and you would have a case, and then you'd have to make the diagnosis and then also use the ICD-10 codes. And one of them had a patient had B12 deficiency. Their antibodies were, no one said anything about them being positive, and the only answer option on the key was pernicious anemia. So this is an important point to kind of parse out is that not all B12 deficiency is pernicious anemia. Pernicious anemia is only diagnosed when you have those positive autoantibodies. So when you have someone who has B12 deficiency and there's no real reason for it, like they're not vegan, they didn't have gastric bypass, there's no obvious reason. When you recheck their B12 after you replete it, you should throw on those autoantibodies if there's no reason that, you can blame this B12 deficiency on. What about this symptom when the tongue becomes sometimes painful and like depapillated and smooth? Good. Glossitis. That's something that is seen, can really be seen with any of the nutritional deficiencies, like angular cheilitis can be seen with any of the nutritional ones, but it's often in the cases for B12 and folate. So here's another CBC, and this one I have like other corresponding labs with. So you have MCV. Here it's reading as a little elevated. MCH is reading as a little elevated. That doesn't necessarily mean the cells are that much more dense. It's just they're bigger, so they do have a higher hemoglobin content. So nothing really wild here. The B12, the range, every lab is so different. You'll see ranges like some will say normal is 150 on the low end, and then the high end is 1200. This one is 200 to 900. I will say through my experience, and you can, read into this and up to date in other places, and they all kind of concur with this, that most people feel good around like 600, and you can have symptoms of B12 deficiency at the lower end of normal. So just because the lab says, okay, that's normal, that doesn't always mean that the symptoms can't be blamed on it because it's an enormous range. So this is what I wrote to the patient. I work primary care, so I have like everything. And his name's super generic, so I didn't even chop that out because there's no other like identifier. So going down here to the third line, white blood cells are back down. He had like a little bump in his white blood cells, probably sick, maybe a smoker. I don't really remember. Oh yeah, here we go. Chest x-ray at the bottom, some air trapping consistent with smoking. Smoking is a very common reason for them to have white blood cells be a little elevated with a little neutrophilia, because neutrophils, they respond to bacterial infection, but also inflammation. But back to what we're talking about today, which is here just for orientation. Your red blood cells are slightly large, which can be B12 or folate. B12 was normal. We didn't check for folate. And the reason why is because in our lab, I ordered the test, and then our lab tech, performed, she did the in-house CBC, because this is before I refused to do it. And then she gives it to me and says, like, is there anything you want to add on? So she said she could add on only one test, because each tube, usually like a purple top, which is a CBC, you could run like 3 tests on it. And that's the same for most labs. So anyway, she says you can do 1 test. So I picked B12 because B12 is more, again, urgent to treat. So what I said for him is I don't want him to have to come back in and check folate and like keep chasing this. Like, it's a little big, it's not a big deal. But I've known this patient for years, and if anything is out of range, he is looking it up. He's worried, and that's okay. In general, to like, again, be engaged in your healthcare, but just really, he wasn't going to accept that we were doing nothing about it. So here, you can take an over-the-counter B complex. It includes B12 and folate, and then we'll recheck them with your next blood draw in 3 months. No real urgency there. So which vitamin has longer stores, B12 or folate? Yeah, this might remind you of that case in the PowerPoint where we had a patient who like recently became vegan, and it's like, 2, 3 weeks later or something, and she's feeling tired and she's wondering if it's B12 deficiency. No, B12 stores in your body for years. We eat it in micrograms, we store it in milligrams, so it's not going to run out quickly. Folate, on the other hand, does run out quickly. So when we have hemolytic processes, acute chronic hemolysis, we always want to make sure we replace folate. And that's a key point for exam questions as well. So next we have a 45-year-old man. He's got fatigue. He has glossitis, hemoglobin 9.8, so low, MCV 112, high, so macrocytic anemia. B12 is normal, neurologic exam is normal. He has a history of epilepsy, seizure disorder, rheumatoid arthritis, autoimmune arthritis. Which of these medications is most likely the cause of his anemia? So we've got here you have to do 2 steps. You have to recognize that, okay, it's a macrocytosis. There's a big, differential for it. Top one's B12 and folate. B12 is normal. Neurologic exam is normal. So they're pointing us towards folate. And then we go back to that slide in the PowerPoint that had like drug causes. And one of the common ones was phenytoin, which is used for seizure disorders. Another medication that's talked about a lot through these lectures, especially through exam 1 material, is Bactrim, TMP-SMX. That's another one with chronic use can lead to folate deficiency. And people always wonder, well, why would you use an antibiotic long term? There's indications for it. A lot of the bigger indications for Bactrim chronically would be like with organ transplant patients that have some immunodeficiency. Other ones, you see chronic antibiotics used in disorders like bronchiectasis, not usually Bactrim, but there are indications for chronic antibiotics. So definitely make sure you keep that in the back of your mind. They're, highlighted on the slides too. So when we look at B12 versus folate, again, the exams love to pit them against each other. I just put a chart here summarizing like the big ones. B12, they'll give you neurologic symptoms. It takes years to develop, and both homocysteine and MMA go up. Folate, no neurologic complaints. Symptoms come on a lot quicker, and only the homocysteine is elevated. So pay attention to those clues whenever you have a case with a macrocytic anemia. Now looking at just a bunch more of them, now when you look at this and everything is in bold and you see this asterisk, like me, you're probably like, oh no, what's going on with this, right? But if you look, white blood cells, it says 6.9, that's within range. The reason that it bolded these and put the asterisks, another reason why I hated this machine, is because that happens if there's sediment. whether there's like sediment within the machine, like it wasn't cleaned, or if one of the cells is abnormal or like clumps, anything can throw this off, and then it makes it look like this, and it's frustrating. Um, so we're focusing mainly down here. MCV says high, MCH again says high, just because those cells are a little bit bigger, not necessarily they have disproportionate hemoglobin concentration. There's one disorder that we'll talk about that does have that. But here, not so dramatic. Oh, question here in the chat. 1 second. Oh, I misspelled that too. But it's phenytoin, the medication. Yeah. I should have just said it out loud instead of trying to type it and mess it up. Yeah, okay. So slightly elevated red blood cells, but still nothing to really talk about. We looked at their TSH, everything's fine. B12 290. So that's pretty low. So when we look here, this is just another case. In this case, I would tell the patient same thing I told that patient Bill. You're not anemic. Your red blood cells are on the higher end of normal. It's nothing to be concerned about. We did run your B12. It was the lower end of normal. And these patients who don't really have any symptoms and they don't have an anemia, I'm fine just using PO supplementation, just taking oral B12, sublingual B12. If someone wants to come in for B12 shots, if someone wants me to teach them how to do B12 shots, I don't care. I will. I have a low threshold for that. It's way more convenient to do something once a week than it is to like remember every day, unless you're someone who already takes a lot of medication. So I don't mind doing that. Looking at a few more cases, here we have a patient, finally, someone who is anemic, red blood cells are low, and look how much higher this true and significant macrocytosis is. So MCV here, 109. Now we look at this patient's labs. B12, not bad. 604, that's good. That's not driving the macrocytosis. That's not driving the anemia. The most likely cause is this TSH. So when you look at macrocytosis, you want to look at, okay, B12 folate, low-hanging fruit, easy ones to knock off and test. Other things, liver function tests, thyroid function tests, because anything that has a hand in like forming and like lipid membranes and transporting lipids and metabolism, those kind of issues can play into forming a macrocytic cell. So when I'm looking at, you have that mnemonic big fat red cells, there it's a long list, but top ones, B12, folate, thyroid, liver function. And we'll look at a couple. This one happened to be caused by the thyroid, and after she was back to being euthyroid, it resolved. That was case C. Same patient also has like a mild transaminitis. Transaminases are your liver function tests, AST and ALT. So we have two things we could probably blame the macrocytosis on, liver or thyroid. Here's another case. You can see MCV also pretty high, 110. So this is case D up here. So same patient, liver function tests are abnormal, thyroid function tests. I mean, it's not, you'll talk about in ClinMed Indo, like how significant this would be. I can't exactly remember if this patient was on thyroid medication or not. But we could certainly, if we're just talking about what could cause macrocytic anemia, we again have two culprits. Thyroid looks like there's possibly some dysfunction and certainly some liver inflammation there. So how do I explain that to the patient? The liver tests remain elevated. We'll order a liver ultrasound, talking about the differentials there. You'll talk about that more in ClinMed GI. Red blood cells still large, likely due to a liver issue, possibly the thyroid, still underactive. And here, oh, I'm remembering her a little bit more. She has Hashimoto. She has autoimmune thyroid disorder, but her thyroid was normal for a while, and then now we're starting to see it dip. So since she had symptoms, I did start her on like a teeny tiny dose of thyroid. So just showing you like how I would explain that to a patient. This is another patient who came in and said, I think I'm anemic. Can you check for it? Can you check for the common causes? And when asking her, like she says, like, I just feel tired. And tired is one of the worst primary care complaints because the differential is huge. And she didn't have any like focal kind of anemia symptoms. She was just tired. She wasn't, you know, having dyspnea on exertion, no pica, no like specific to this deficiency, nothing else besides just being tired. But again, fatigue is a huge differential. So we certainly include CBC, B12, folate, all of that. It was normal. Here's her CBC. Here's her BMP, all fine. Did an iron panel for her, B12, folate. So looking at these numbers, here you can see that it didn't register anything as abnormal, but looking at the B12, I mean, it's not far above abnormal. In her ferritin, which is the storage of iron, the range is huge, 7.3 to like 300, and it's only 22, so lower in there, but still not like frankly deficient. So this is what I write in the portal. As mentioned, there's no anemia. And I say as mentioned because we did talk on the talk when she was there because I got the CBC back immediately. So no anemia, but we checked for those ingredients. And the same way I talk to you guys about it, I say like, we need these ingredients to make a red blood cell. That's the same way I talk to them. So we checked iron, folate, B12. B12 was low. Let's start a supplement. We can also give you a B12 injection when you come in for your Lexapro in a few weeks. She had just started on it, so we see them a few weeks later. And we can go from there, but nothing is critical. Like she doesn't have to come in and get immediate IM injections, but if she had wanted to, I wouldn't have pushed back on that. So any questions about macrocytic anemias? I know your exam is like 2-ish weeks away, so hopefully the questions will start flowing as we progress. Looking at normocytic anemia, so MCV is within the normal size range. First, we want to look at pregnancy. So here we have a chart showing red blood cell volume, which is pretty steady. It increases in the later weeks of pregnancy, but plasma volume and total blood volume are going to increase significantly, and plasma is mostly water. So how would having more water cause an anemia? Yeah, a dilutional anemia. So same thing with congestive heart failure, states of fluid overload that can cause an apparent anemia, and those dilutional anemias can still be symptomatic. And I apologize. I replied back to like an individual chat. So then my chat didn't like automatically scroll with your answers. So I think I missed a couple questions. So answer here is delusional anemia. I'm just scrolling back up to those questions. So a question here is what were you saying about disproportionate hemoglobin with high MCV? Yeah. So when a patient has a macrocytosis, which is high MCV, often the lab will also record a high MCH, that's the hemoglobin concentration, and the patients won't be truly hyperchromic, which is high MCH. It's really that the cells are bigger, so they have more hemoglobin concentration, but it's not disproportionate. It's proportional to the size. When someone has a true hyperchromia, both the MCH and the MCHC will both be elevated. If it's just the MCH, it's often just it's a bigger cell, so there's more hemoglobin. It's not disproportionate. And let's see, other ones. When there are two possible causes, like with liver and thyroid function on exam, oh, on an exam, it's these cases are real life cases. You'll see that there's like multiple differentials and you kind of have to concurrently work both of them up. But on your exams, PANCE, PACRAT, my exam, which is your first focus right now, which is fine, there's going to be just one answer. It's never going to be like, well, it could be the thyroid, it could be the liver, which one is more likely? No, it's going to be one cause of macrocytosis in the answer list. It's going to be straightforward like that. And then another one, could HL hyperlipidemia be a cause of anemia? Um, yeah, if someone has hyperlipidemia, especially if it causes like a fatty liver by itself, just like primary hyperlipidemia, it really shouldn't. But if it has like a secondary complication, like fatty liver, if there is some other kind of like lipid disorder, like forming abnormal lipid, then it could affect the red blood cell membrane, but not typically just like you have high cholesterol. It would need to like cause a secondary complication. Good. I think that's all of them. Oh, and then another question here in the previous example. Yeah. So she asking here, why does the folate seem high? It's highlighted as orange. The only reason it's highlighted as orange is because if you click on it in our EMR, there's a note like about GFR, and the note about GFR, which is kidney function, will tell you like which equation they use to estimate GFR. In folate, if you click on it, it'll just have like a more info about the range, but this is normal. This isn't like exceedingly high. Yeah. And that's another reason why like you can't just like look for the colors, because every lab will report them differently and it just really screws you up. Yeah. I'm glad you asked about that. All right, so here we were with dilutional anemia, and move into this one. So we also have anemia of inflammation, which can be microcytic, can be normocytic. So when we have inflammation, it upregulates this protein that comes from the liver, that causes the macrophages to kind of like slurp up the iron and sequester it and hide it. Starts with an H. And I teach physiology and I talk about it because I also teach heme, but I really don't remember it being talked about in physio like way back. um, does anyone recall what's upregulated in inflammation and blocks iron absorption? And this will be a hint. So it's hepcidin. So in this example here, we have anemia of chronic disease. And I'm just going to change the color because I thought yellow would be great, but how can I hide the red? We'll just leave it there for now. So you have hepcidin overexpression in anemia of chronic disease, which means there's too much hepcidin, and then that blocks iron absorption. Here we have equal amount hepcidin, normal levels. Hemochromatosis, which we talked about last lecture, causes iron overload. There's not enough hepcidin expression, which would block iron absorption, so we hyperabsorb it and we don't sense it well. Trying to see, oh, there we go. Get that out of the way. So answer here was increase in hepcidin. That's what drives anemia of inflammation. So when we have iron deficiency and anemia of chronic disease, as I mentioned, both of them can cause a microcytosis, and you might have to choose between, well, which one is driving it. With iron deficiency versus chronic disease, which iron indice will kind of be a hint for us? Something that's low in iron deficiency, but high in inflammation. That's this side. So ferritin is the answer here. Ferritin will be low in iron deficiency. It'll be high in inflammation. Ferritin is an acute phase reactant, which is going to this left side here. The nonspecific markers, acute phase reactants, they are increased with any type of inflammation. ESR, CRP, ferritin. Also, platelets are an acute phase reactant. Factor VIII is an acute phase reactant. There are a ton of them that we'll talk about as we progress through this course, and also we'll talk about them within lab diagnostics. So if you have 2 cases of microcytosis and you have, like, say you have a case in real life, not on the exam, You have a case, you have a patient who has something like lupus, highly inflammatory, but they also have an iron deficiency. You might get a iron panel back that says iron is low, TIBC is high, but ferritin is high. And you're like, wait, ferritin's supposed to be low if it's iron deficiency. What's going on? The inflammation could be driving that ferritin up, which is why we get an iron panel, because each individual marker has a lot of drawbacks to it. So an anemia of CKD, what's deficient? What is the kidney supposed to make that stimulates the red bone marrow to engage in erythropoiesis? Nice. Yeah. EPO. Good. So here's a patient, 28 years old, fatigue, nosebleeds, frequent infections. So right there, before we even look at the labs, we look at the symptoms. And his symptoms, that's alarming because they're associated with three individual cell lines. Fatigue, that's red blood cells, that's anemia. Nosebleeds, that's platelets. Frequent infections, that's white blood cells. So we've had three cell line issues coming to us. Then we look at his labs. Hemoglobin, low. White blood cells, low. Platelets are low. So what do we call it when all three cell lines are down? Red blood cells, white blood cells, platelets. Whole thing depressed. So the term for it, you guys are going two different ways, which is fine, and this is where I want to lead you. When all three cell lines are down, it's called pancytopenia. And one of the causes of that is aplastic anemia. It's not always aplastic anemia. There are other causes, but that is one of them. The term, though, again, is pancytopenia. Then we look at reticulocytes, very low. So reticulocytes, again, are those baby red blood cells. If the bone marrow was picking up the slack and saying like, all right, you don't have enough red blood cells, I'll give you what I got. It'll start spitting out reticulocytes if it's healthy. But here we see reticulocytes are low in the setting of anemia. That's a red flag. That tells me there's some central bone marrow issue. MCV here, normal, so normocytic. And bone marrow biopsy is hypocellular, which means we're not really seeing a lot, and that is consistent with aplastic anemia. So lots of examples there. And then going back to aplastic anemia, there's disorders like, there's some disorders that cause like a red cell aplasia, which is just an aplasia, lack of formation, just going to cause an anemia. And then aplastic anemia can be set off, like in the setting of someone who has sickle cell and they get an infection on top of it. It can set off an aplastic anemia. It can be they have a congenital issue. It can happen as a result of taking chloramphenicol, which I think you guys had your antibiotics lecture some already. Chloramphenicol is an antibiotic that's often associated with that like gray baby syndrome. It's not used that often. But in heme, they love testing that because it's a funky reaction. So chloramphenicol, another culprit for aplastic anemia. So lastly, looking at these hemolytic anemias, you have a patient who's 25, fatigue, jaundice, splenomegaly. So jaundice and splenomegaly, what type of kinetic process is going on there? Do you think this is decreased production? Chris, you got it. Hemolysis. So when you have jaundice and splenomegaly, it's often hemolysis. The jaundice comes from lysing those red blood cells and releasing that pigment. So that's a hint there for us to start. And with heme, you really want to you can try to just look for buzzwords, and that's going to help you often. But when you're reviewing and you're getting ready for the exam, it's helpful to okay, I knew this was the answer, but then perform a post-mortem on it and go through and tell me oh, this is what told me that. This is what told me this. So anyways, labs reveal anemia, increased MCHC, so we have dense red blood cells, decreased MCV, small, dense red blood cells, and a bunch of spherocytes. So the answer was, in there, we have a spherocytosis. What's the pathology? What causes a spherocytosis? What's deficient? Yeah. So what's deficient in spherocytosis is spectrin, that portion of the exoskeleton. And G6PD deficiency and PK deficiency, those are enzymatic deficiencies. And what's deficient is in the name. G6PD deficiency or missing G6PD, sorry, hiccups, and so on. So I want to point you here again, this is a smear of spherocytosis. You can see not all cells are affected, but some of them we have, and the arrows are already pointing, these small, microcytic, low MCV, very dense, high MCH. So when we were in anemia part 1, we talked about small, pale RBCs over and over, thalassemia, iron deficiency over and over. Here we have small cells, densely packed, high MCH, high MCHC. Again, deficiency is in spectrin. Another test is high yield to ask about is, what is the diagnostic test? You can do a smear and see the spherocytes, yes, but we want to see how they react. So this is a very high yield test. Starts with an O. Coombs is actually to determine if there's an autoimmune process happening. And that's like the main thing you really need to know about Coombs for at least exam 1 is it tells you, is there or is there not an autoimmune hemolytic anemia? But the answer here is osmotic fragility tests. They take those red blood cells and expose them to different osmotic concentrations, and these cells lyse at lower concentrations. So you don't need to know the ins and outs of the test, but you do need to know that spherocytosis is tested with osmotic fragility, which is like in red on that slide too. So which lab set is consistent with hemolysis? Good. It takes you a minute to read through them because they're very similar. Yeah. So answer here is C, LDH, nonspecific, is increased, and then increased bilirubin. So going back to this case, or this one that you're asking about, the reason why the MCHC is elevated is because these cells, as you can see here, the MCV is down, the volume is down, but it has what would be a normal amount of hemoglobin for a regular sized cell. So here they are densely packed, and that's what drives that MCH and MCHC up. Small, densely packed cells, so the hemoglobin concentration is higher here because they're coming like off the line like this, out of production this way. Good. What about a GI manifestation that can result from chronic hemolysis? You can even think back to our sickle cell case from last week. The patient had the scar in the right upper quadrant. Yeah, gallstones. Sure. Because again, when we lyse those red blood cells, we release bile, and increasing that bile concentration increases sludge in the gallbladder and can lead to stones. I'm not sure if you've started GI yet, but you'll talk in GI about like the different composition of gallstones, and most of them are made from this. Not made from hemolysis, but bile is the big driver there. So we have a 45-year-old, fatigue, pallor, jaundice, again looking towards hemolysis. Labs reveal evidence of hemolytic anemia, thrombocytopenia, elevated LDH, peripheral smear shows fragmented red blood cells. So there's a lot of like distractors here, but it's basically asking you, what's the other name for fragmented RBCs? Yeah, schistocytes. Good. No one wants to type it out, of course. I don't want to type it out. So these fragmented red blood cells, that indicates that there's a hemolytic process going on. So this is a screenshot. I just deleted the person's name from last week. I like briefly talked about it, but I thought it was more relevant to discuss here. So when we talked about hemochromatosis, which is iron overload, which does not cause an anemia by itself. It is a chronic disease, so if it's uncontrolled, they can have anemia of chronic disease, sure. But as a disease process itself, not as a complication of it, it does not cause anemia. But when you look at disorders like sickle cell, spherocytosis, any of these cells, like severe thalassemia, they can have hemolysis. And when we lyse those red blood cells, there's iron in there, right? So could a hemolytic anemia cause iron overload? Not typically. When you have an acute hemolytic anemia, when you lyse those red blood cells, that iron just gets recycled. So, say, and this isn't what really happens, but if we kind of like magic school bus it and just focus on one red blood cell, you have one red blood cell, it's lysed, pops open, here comes iron and all the other stuff, and we reuse some of that and we piece them out, and it becomes the color in our poop, and so on with red blood cell recycling. But looking at that iron, I'm now going to reuse that iron and I might store it as ferritin. I might use it immediately. And that tells my body I've got enough stores, right? So when I eat an iron rich food, it's maybe doesn't absorb as much from the food because I have enough stored. So in again, a hemolytic process, since that iron is recycled, we really just reuse it, and there's not really a good way to get rid of it, which is the issue in hemochromatosis. But we don't end up with like an acute overload because it just stays within the body and gets reused. When we have a chronic hemolysis, like sometimes thalassemia can have like a chronic background hemolysis, sickle cell. When you have that chronic hemolysis, what can happen is patients can, oh shoot, I'm forgetting how to go about this. Um, oh, sorry. There's so many different anemias. So you often have like transfusion dependence. So when someone has transfusion dependence, they can absolutely get an iron overload. In other disorders, so you can have it from iron, like physically getting more iron, sure. Sometimes those disorders can cause just ineffective erythropoiesis, like the bone marrow can be affected, which is why in thalassemia we can have like physical skeletal abnormalities, chipmunk faces, all of those abnormalities that we talked about, hair on end, spiculations and stuff. So it can impair like the iron factory in the red bone marrow. So that can cause us to hyperabsorb iron. But that's typically a small issue unless there's transfusions. So unless they have transfusions, you typically don't see a significant iron overload because our body is good at recycling it to a point. Now, when we have hemochromatosis, we exceed that level of what we can store, and that's a whole separate issue. Does that clarify the question a little bit better for the person who answered it? And I deleted the name because I didn't want anyone to be like specifically called out, but I also forgot the name. So if not, we could stick around and talk about it a little bit more. We just have a few more slides here, and these are kind of harder. So there's a disorder that causes this triad of hemolytic anemia, venous thrombosis, and pancytopenia. So there's also a case that goes along with it. We have a 30-year-old who has recurrent episodes of hemolysis, hemoglobinuria, which comes from the hemolysis, and thrombosis. We look at his red blood cells, white blood cells, platelets, all low. So pancytopenia, hemolytic anemia, and you don't have to remember like the cell surface markers, but I put it in here just in case it was a hint that reminded you. So does anyone remember the disorder that I'm talking about here? Pancytopenia, hemolysis, and venous thrombosis. And they often have nocturnal hemoglobinuria. So that's most of the name. So it's paroxysmal nocturnal hemoglobinuria, PNH. So go back to that one when you're reviewing for your exam, and you'll see the things that are like highlighted in red to include this triad, but also like the PIGA gene, which is the driver for it. So right now, going through this material, this is not one you can remember for sure. But the answer here is PNH, paroxysmal nocturnal hemoglobinuria. Then we have two just quick cases. We have a patient who has a history of G6PD. They have symptoms of a UTI. Which antibiotic should I avoid because there's a risk of hemolytic anemia in those that have G6PD deficiency. Yeah, Bactrim. We talk about Bactrim a lot in these lectures. Oh, interesting. Looking in the chat. Um, and then another one here, this is just a reminder of the antibiotics, Bactrim, but also nitrofurantoin, which is macrobid, which is actually one of the first line medications for UTIs. If you have a case where it says someone took nitrofurantoin and they developed a hemolytic anemia, you want to think back to G6PD deficiency. Same thing for Bactrim. So come back to those. Bactrim, we talk about here in G6PD deficiency. We also talk about it causing folate deficiency with chronic use as well. So that's it for heme part 2. Like I said, I wanted to end a little bit early for you, but I'm here. Like, if you guys have questions, you can unmute, talk to me, type in the chat, email me, whatever you want. But I'm happy to stick around. I just didn't want to like talk up until the very last second again. Yeah, of course.